Now we are going to the next speaker. May I invite Dr. Padmarekha Jirge. He will speak on AMH predictor of pregnancy outcome of IVF.
Good morning, everybody. It's a wonderful time to be here to learn from each other and to get educated and enlightened during these 3 days of excellent academic program. So I have been asked to speak about AMH, which is a very favorite topic of mine, but with a twist to say whether it is a predictor of pregnancy outcome. It's not about ovarian response, but about pregnancy outcome. Does it really tell us about if somebody has a good AMH? I know that we are very interested to look at AMH. These days, many of the patients do come with 3 to 4 reports of AMH before they ever reach us. And we need to understand what it is telling us or what all it can tell us so that the patient and the couple is counseled appropriately before we plan any treatment. So we'll just go through a brief background for AMH and its secretion and briefly about AMH and ovarian response. AMH, and then look into AMH and pregnancy outcomes. So we all know that ovarian reserve plays an important role in the ovarian response to stimulation during IVF. So when we talk about ovarian reserve, we are talking about the quantity of follicles present in the primordial follicular pool. It is not necessarily talking about the quality of the oocytes, it's the quantity of the oocytes. And AMH is considered as a robust quantitative marker of ovarian reserve and response. Whether its role goes beyond prediction of ovarian reserve is contentious at present. We do know that of all the markers of ovarian reserve available, it is the maternal age which is known to predict the pregnancy. It is considered as the only single most important proof of oocyte quality, and live birth is considered as the single most proof of oocyte quality. And age is the only predictor of ovarian reserve and oocyte quality. But can we add AMH to this equation, and does it actually have a predictive value for oocyte quality and pregnancy outcome is something we will look into over the next 15 minutes or so. We all know that AMH is a glycoprotein belonging to the transforming growth factor beta superfamily, and it is exclusively produced by the granulosa cells. There are some fine differences between what we can learn from AMH and AFC, even though for predicting ovarian reserve, both of them have the same capabilities. We do know that AMH, do we have a pointer here? No. Okay, so the brightly orange colored follicles are the ones which produce the AMH. So we can see that it is the preantral follicles and small antral follicles are the ones which secrete AMH exclusively. By the time they become large antral follicles, almost AMH secretion is over, and same is the story with the atretic follicle. So it is coming from follicles which are not necessarily identified on the ultrasound. So it's a step before what we learn from antral follicle count. So if we diagrammatically represent the same information, so it is the recruited follicles, primary follicles and secondary follicles, and which are very small preantral and antral follicles. These are the ones which secrete the AMH. So once AMH became widely available, sort of, a feeling came into our minds that it is actually a crystal ball. It can tell us almost everything we want to predict when a couple approaches with female infertility. Of course, in the IVF setting, prediction of over and poor response. And does it predict the pregnancy as well? And beyond that, in a non-IVF setting, we want to actually learn a lot about those who have infertility but do not necessarily need IVF. Can AMH be used for predicting various timelines in that population? Or in fact, can we extend it to general population to learn about how long somebody can defer pregnancy, or whether they should take any active measures to freeze their oocytes or prioritize conception. So there are a lot of areas where AMH has been tested to see whether it would be helpful. And during this talk, we will concentrate primarily on the prediction of pregnancy. We know that AMH has been now proven to be one of the most robust markers to predict hyper response as well as poor response, and it has the highest specificity and sensitivity, over 90%, to predict both of these, and it is known to predict both normal, high and low response with highest specificity and sensitivity. And when we mean ovarian response, we have to remember that we are talking only about the IVF scenario where we are using conventional ovarian stimulation. So ovarian response in any other context, these markers may not be very helpful. So when we say ovarian response in the setting of IVF, we are referring to conventional IVF protocols. So that is a very limited area where AMH can help, and because it is known to be the robust one of the two robust markers, it's been used to individualize the ovarian stimulation. So different protocols and different starting doses of gonadotrophins can be used for the same. So what we conclusively know about AMH is that AMH-based protocols do not necessarily increase the pregnancy rate, but they improve the safety of treatment in hyper-responders by reducing the incidence of OHSS and reduce unexpected cancellations in poor responders. And both AMH and AFC are equally good in predicting ovarian response in IVF. But what is our expectation is, if somebody comes with a good or normal AMH, can we say that she has the highest likelihood of achieving pregnancy and live birth? So this is what we will see over the next few minutes, whether it does actually have that ability. Before we actually analyze its ability to predict live birth, we actually need to know certain intrinsic things about AMH, which are related to the assay methodology used and how the assays are performed, and factors which can actually affect AMH. Without understanding these, interpreting an AMH value may not actually guide us to counsel the couple appropriately. And then there are other extrinsic factors which have nothing to do with ovarian reserve, nothing to do with oocyte quality. It could be something totally unrelated, like bad uterine condition or cervical condition, which will prevent pregnancy from happening in spite of having good quality embryos. And also, when we interpret the data available, we need to actually closely look at whether they are reporting live birth rate after a fresh transfer or whether reporting a cumulative live birth. So that can also play a role in deciding whether AMH is helpful for that purpose or not. We know that AMH assay over the last 15 years has gone through a great evolution from the ELISA test initially available, DSL and IOC, and then Gen 2 assays. We have now moved on to either ANSH assay, which is still an ELISA assay, which has a very high sensitivity. But one of the things with ANSH assay we need to remember is that we need to know whether the sample has been tested, a fresh sample has been tested, or a frozen thawed serum sample has been tested, because the values can be significantly different, and the frozen thawed samples give a higher value, clinically significantly higher value than a fresh sample analysis. So this is something very important. Otherwise, without knowing that, we may interpret the results very inappropriately. The two other assays available and most widely used are the Beckman-Coulter automated and Roche automated assays. All the others are semi-automated assays, and these are fully automated assays which have made life easy for many of the labs. Reports are available within no time, and fresh samples can be analyzed. We don't have to freeze the samples. But if for some reason a lab freezes the sample, both these assays also yield slightly higher AMH levels when the frozen sample is tested, but they're considered to be very marginally more than the fresh sample analysis, so they may not be very clinically relevant. So we need to know what assay is being used. And then there is a host of things. As the woman ages, smokers actually have a low ovarian reserve, low AMH. Pregnancy, undiagnosed pregnancy can also lead to a low AMH level. Previous ovarian surgeries, genital tuberculosis and other infections, malignancies being treated, and then query about obesity. There are reports saying that it may have an impact or it may not have a negative impact. And definitely ethnicity. We know that many of the Asian ethnicities, including our own ethnicity, is associated with a age matched. If you look at the age matched Caucasian controls, we have a lower ovarian reserve. So we need to be aware when we take data from the Western world. We need to be aware of directly, before applying it directly to our patients, we need to be aware of these differences. So we know that when we talk about pregnancy, as the number of oocyte yield increases, the pregnancy rate increases. So is it purely, AMH is just a reflector of oocyte numbers, and because somebody has a good AMH, we know that she will yield good number of oocytes, and is that the only reason that the pregnancy rate increases, or is AMH level inherently telling us something? So now looking at some of the data published in the last 13 to 14 years, the first one came from the US, looking at those who had AMH level less than 1.05 and those who had more than 1.05. What they have identified is that those who had AMH below 1.05 is they had a lower birth rate in all age groups, irrespective of their age groups. Even if they were younger than 35 years, they did have a lower pregnancy rate, irrespective of all other parameters. And then two more studies were published in the subsequent 2 years, looking at women up to 40 years of age, and they were categorized into those below 31 years, 31 to 37 years, and then above 37 years. What these two studies again reiterated is AMH is an independent predictor of live birth, irrespective of the age, up to 40 years of age. So meaning that somebody who is young and has a low AMH is likely to conceive, is less likely to conceive compared to somebody older than her, but with a better AMH value. So then came the systematic review, which looked at, this is not a systematic review, this looked at the national database, looking at the pregnancy rate and cumulative live birth from a large set of patients, more than 1,000 women undergoing IVF and ICSI. What they did see that with every unit increase in AMH up to 5 nanogram per ml, there is an increase in the pregnancy rate and live birth rate in women undergoing IVF or ICSI. And this is true even after adjusting for age and oocyte yield. So it's not just AMH is reflecting oocyte yield. Even when we do robust statistical analysis to adjust for age and oocyte yield, these women have a higher pregnancy rate as the as the AMH value increases up to 5. Of course, the study did not adjust for other coexisting causes, endometrial factors, any systemic influence or paternal role, but they did make the conclusion that the association is very important because it remains true even after adjusting for age and oocyte yield. So in those of similar age and oocyte yield, those women who have a higher AMH value have a higher live birth rate compared to those who have low AMH value. However, this is possibly true for up to 40 years of age. But beyond 40 years of age, irrespective of AMH value, the age factor plays a role, so that, when they're younger, even if they have, oocyte quality is probably, oocyte number is not a major issue because the quality is in general considered good and they're more likely to have euploid embryos. But as they grow older, the quality is affected, so that cannot be rectified by just yielding more number of oocytes. So this is another study looking at AMH and cumulative live birth rate in women specifically with diminished ovarian reserve. This is from SART core registry, so included a large number of women, and they did not only look at live birth rate, they looked at cumulative live birth rate. That is live birth resulting from one IVF, including all the transfers done subsequently from that IVF cycle. So they showed that there is strong correlation between AMH And obviously, age, we know, number of oocytes retrieved, number of M2 oocytes retrieved, number of embryos transferred and cryopreserved, significant association, and across all age groups. If we see here, from those below 35 years and to those above 42 years, as the AMH value increased, the chances of live birth, cumulative live birth increased. So this is how the data has been summarized. Again, I need to highlight that this is only looking at those who had diminished ovarian reserve, which is very relevant to our population. So we can see here that across all age groups, women with higher AMH had better pregnancy rate, and they had better live birth rate and better cumulative live birth rate. So in IVF, AMH is also a predictor of pregnancy, that is quality of oocyte, and the highest correlation was noted in younger age groups. So what about, this is the latest meta-analysis looking at the other extreme, that is those with PCOS. So when we look at this, when we look at women with PCOS, and we would like to use AMH as a predictor of live birth, then the equation changes. And we can see that compared to those who have an AMH of around 5, those who have AMH above the 75th centile have a significantly reduced pregnancy rate and live birth rate compared to those who are in the lower quartiles, but still those diagnosed with PCOS. So the equation here is different. And that is not related to freeze-all policy, but it is related to, probably, they say that it could be related to the endometrium or the oocyte quality. But definitely, as the AMH increases dramatically, the success rate tends to decrease. Now coming to there have been 3 systematic reviews and meta-analysis looking at whether AMH can be used as a predictor of live birth rate. And the first 2 meta-analysis actually concluded that yes, it is a weak predictor of, there is a weak correlation between AMH and the live birth rate. And the most recent one also, can I just, I need about 20 seconds. Yeah. So the latest meta-analysis also says that there is an improvement in the pregnancy rate as the AMH level increases. This is despite, irrespective of the number of oocytes retrieved. So young women may have a higher number of oocytes, and a high proportion of them are of good quality. Thus, the ovarian reserve is not a major limiting factor for ART success. However, older women have a lower number of oocytes, and lower proportion of them are of good quality. So in these older women, greater ovarian reserve, as reflected by higher serum AMH levels, could compensate in part for the lower oocyte quality, resulting in better ART outcomes. So to conclude, ovarian response may not always equate with live birth rate. Age is still considered as the only predictor of pregnancy outcome. However, the current evidence does suggest that AMH values independently correlate with cumulative live birth rate following IVF. Very high levels in women with PCOS, that's above the 75th centile, is associated with lower live birth according to the current evidence. While utilizing AMH for prediction of pregnancy outcome and counseling the couple, both the intrinsic and extrinsic factors which may affect the serum levels should be taken into consideration. Thank you.
Thank you, Dr. Padmarekha, for raising such a controversial topic, AMH. AMH is also controversial because whether to do for all PCOS, whether to do for endometriotic surgery, but she has nicely told about AMH and the ART. Now we'll finish the questions because afterwards is no time. So, madam, I want to know, you told that 5 nanogram AMH will have a better pregnancy outcome. Is it because of the conception rate or the pregnancy rate or the quality of the oocyte? What is the secret behind the high live birth rate for a adequate AMH? High, yeah. It is not there like PCOS. So what is it?
Yeah, I mean, in the group of women with PCOS, once the diagnosis of PCOS is established, those who have AMH in the lower quartile are likely to have a better quality of oocytes compared to those who have very high AMH, because some of them, a portion of them who have very high AMH may not respond very well to stimulation.
That we do.
That is one of the reason. And there is some evidence that it could be the oocyte quality, but the authors could not actually identify one specific reason as to why the higher quartile women tend to have lower success rate.
Thank you, thank you. So, may I request the audience not to murmur and gossip. If anybody is having anything, you go outside, gossip and come. Because all the interesting topics are going on and we listeners are listening to them. Thank you very much.